let me recap what I understood from you in the last part of the conversation is that
Mm.
you outlined three different strategies through which UK is able to scale up the number of tests. So, one,
Yes.
super labs like Milton Keynes uh, is one of them.
Manchester, yeah. Manchester,
Uh,
Manchester,
yeah,
and
yeah.
Glasgow.
And then there are big NHS labs like in
Like,
King,
yeah,
Birmingham. And then there are research labs which have
yeah.
joined in.
Who've been told not to do anything else except help in this. Yeah.
Yes. And we were talking also about infection and healthcare workers, and you outlined that the infections in lab worker is zero or very close to zero.
Yeah.
And,
We haven't had. Yeah.
and that is because of the biosafety precautions that you take and automation. And secondly, you were talking about the infection and healthcare workers, where I actually lost the connection.
So healthcare workers is the Chinese example is a very good one. If you look at the WHO China COVID mission, which went in February and came back in March, beginning of March, where they did the report, about 2,000 and odd healthcare workers were infected in that particular cohort of 55,000. Yeah, 2,000.
Yeah.
They sent in people to investigate how they got infected, and they found 80% of them, because they live in Wuhan, it was a family slash friends who got them infected, contacts. It's only the remaining 200, which is about 10% of the total healthcare workers, where they think it's actually hospital acquired. But
Right.
they, but every time the healthcare workers acquires it, ends up in ICU or dies, the makes big news. But you have to remember, 80% of them, because we live and breathe in the same area as a hospital, we are likely to get infected by traveling in the bus or socializing or whatever that we've done.
Yeah.
Yeah.
Yeah. Yeah. Yeah.
So that's an important distinction. Unless we actually prove they're hospital acquired, it's very difficult. But to a certain extent, we could certainly say some of the ICU consultants who've been unwell and we made a diagnosis, it's certainly it's gone from some patient to the ICU consultant, and then within the ICU consultant, because they share the coffee room or a tea room or whatever, it may there is a kind of could be an outbreak between them. Same with the pediatricians we've seen. So
Right.
those are all difficult things. Even at work, we have to somehow practice social distancing. Otherwise, the virus or the hand washing. Otherwise, the virus will spread.
Right. Right. May I ask you something in this connection? What about the use of mask? Are healthcare workers in UK moving around in the hospital wearing mask in all places, or is it just patient-specific use of mask?
Well, you have the obviously the public health England. In fact, last weekend I've not seen that thing. They've got now 5 or 6 different strands of what should be worn in which clinical situation. It's looking at it. It's a summary of every week they're revising it, depending on the stocks, depending on the clinical situation. It's become more and more nuanced and more refined now. So obviously, if you're looking at intubation, if you're in the ITU setting, you want to have the full works, the FFP3, the Pinpervious, and blah blah blah, and everything. If you're just taking a swab from someone who's not coughing, then a simple surgical mask, which is impervious, obviously, that's the one you want. Obviously, there's no role for cloth mask at all. Yeah. And in between that, you have non-COVID wards, COVID wards. You have wards where post ICU patients are coming into COVID wards. Yeah. The reason I'm saying is uh, we've had some healthcare workers, all they have is anosmia. They're positive, fit and well, lifting weights, cycling 20 miles a day to work, absolutely nothing else. For 2 weeks straight, the virus is present in the nose and the throat swab. What does it mean? So that does it mean like what it means is there are two aspects. One is before onset of infection. One is after onset of infection. So in the China report, they said less than 1% of people are asymptomatic and carriers. A driver of infection. That advice has dramatically changed in the last 3 4 weeks. Like now they're saying up to 30% of people will be shedding it, just like flu, just like chickenpox, just like measles. You know. So, which is what you would expect from a virus which is transmitting so easily between human beings. So that's one aspect. So that just means ultimately you need to have the capacity in your nation to test every contact of a known confirmed patient who are asymptomatic regularly. Only then you are going to catch them. That's what it means. The every contact. You're looking at 1%, you're looking at the contacts of, let's say, 2.5 or whatever, or 3 people they contact. So you have to test them. So that's the ultimate thing. That's what the South Koreans and the Chinese did. The Germans are about to start that ultimate aspect of it. We are not even there where we are testing all the symptomatic people. Yeah. So then you have people who are symptomatic and then they're clinically well, they're back in the community, and they're shedding the virus for 2 to 3 weeks. This is the known super spreader, whatever. How are you going to identify them unless you have the resources to test them? So they will also be shedding. So all you need is them wiping their nose and then touching the lift button, and that's it. It will transmit. So we have to place them on the standard precautions, standard hygiene, hand hygiene, etc. So again, it comes back to the central question. You got to, the laboratory should not become part of the problem. It should be the solution to the ultimate solution to the problem. I'm so happy from that point of view, from the biologist point of view, but it's really sad we have come to that. Apart from social distancing, the two central tenets are these two, I feel. I mean, regardless of all the politics that are happening, the social distancing is number one. Number two is, of course, the laboratory testing. So that's where I've come to amongst my philosophical biased view of a virologist.
One more question, Sudanwa, and I would like to go back to the testing strategy. When we discussed that there is an E gene for the screening test and the ORF, RNA-dependent RNA polymerase for the confirmatory. Are you doing it in one go as multiplex or
different labs have got different thing. Maria Zambon is of the opinion the RDRP gene is where the virus is multiplying, and that means it's active infection.
Okay.
So that's why they went for the RDRP gene. That's what we are using. It's a okay. Whereas the E gene, which many other companies use, is very sensitive, but it can be seen quite later on also. It's sensitive, yes, but may not be clinically relevant for the initial impression. It's extremely sensitive, may not be clinically relevant. So I don't know how people have come to that particular conclusion. So they also, we went with the two-step one, as I mentioned to you, and then we abandoned. The TACPath assay, for example, that's the one that's being used in Milton Keynes and also in the Glasgow lab and so many other labs. Detects 3 separate genes and MS2 phage. The 3 separate genes are S and N and ORF1AB. So it detects 3 of them. So even if one of them is positive, we're going to call them positive. None of this thing about going back and retesting, because the prevalence is so high. This is like HIV in Africa. All you need is one assay, and you think, yeah, that's it, because the prevalence is so high. Maybe 2 assays. Whereas in Western Europe, you need to have the 2 HIV EIAs followed by a blot or a dot blot or whatever, and a third confirmations highly specific assay. So here, right now, the prevalence is so high. The harm caused to the community is a lot more if you give a false negative. But the harm is a lot less if you say one gene is positive. Yeah, hey, that's what it is. Because quite often, many of the swabs are all self-swabbing. So we don't know how robust they are, whether they swab themselves or their pet dog. We don't know. Yeah.
Sudanwa, that you may be using an internal control gene to check the quality of the samples. Is that?
Yeah. No. Yeah, this all the cancer genomics people wanted a human genome to be done and blah 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 and everything. That's past 10 years ago. We stopped that. We just have the MS2 phage, for example, in most of our assays, and that RNA is what we do. Yeah, we got to have the internal control. Yeah. That's standard.
So basically, spike the samples with MS2 phage and use it as an extraction control and a PCR control.
Yeah. It's extraction control. Yeah. That's straightforward. Yeah.
That's what. Okay. I have run out of questions at this point of time because I'm trying to.
Some questions that Rahul had put on the
Yeah,
thingy.
but I'm trying to digest and absorb what you have said, and I think
Did
it will
I?
take
Did
some
I say
time.
things? No, there are fixing about problems with sampling, so it's a very straightforward. It has to be throat and nose swab in someone in the community. But just like
Yeah,
malaria samples, what we say is in 72 hours, if things haven't improved, re-swab. That's what we say. Also,
right,
because virus transits through the upper respiratory tract, goes down, so we need to have a deeper sample. We've had 5 or 6 cases of patients in ITU where an emergency department they have swabbed and it's negative. In ICU, they've taken the endotracheal aspirator or bronchial lavage, clearly positive. So
right,
that's we seen in influenza, RSV, everywhere. It's the same thing. Nothing special there. It's just that it's comes as a surprise for people that actually throat swab can be negative and patients still. So your radiology is very very important. Then I
right.
mentioned and scaling up tests as many patients need repeats. Yeah, again, how do you de-isolate? So last 2 3 weeks I helped UK draft the guidelines for it. So we say is if someone is asymptomatic they're in ITU or the doctors, you want to step down to a non-COVID ward, you do a test. And if it's positive, still in the respiratory tract, they go to the COVID ward. If it's negative, then you retest 24 hours later and it's still negative, then you move them to the non-COVID ward. It's the same for patients who are immunosuppressed also, how to de-isolate them from rest of the immunosuppressed. Yeah, so you can put them in a Bay Area. So again, if they're symptomatic, don't bother testing because you know that they're confirmed coronavirus. So and then that's how they're symptomatic and everything. It's when they become asymptomatic, all the cough and the fever, everything has come down, you do a test. If it's negative, 24 hours later, one more test. But if it's positive, don't bother testing for 14 more days. No point. Because they'll be shedding. We've seen parainfluenza and everything shedding for 4 to 6 months in patients who are immunosuppressed.
Right.
So just following, so just trying to conserve the resources in those instances. Yeah. So
Exactly.
that's your summary.
Just recollected a few other questions. You have a patient in ICU, let's say, who is ventilated, and there is a possibility of taking, obviously, a bronchial lavage, and there is also a possibility of taking at least a nose swab, if not also a throat with some difficulty.
I would
Now,
go for bronchial lavage. If you don't have a diagnosis, bronchial lavage.
okay, so have you compared the positivity rate of the lower respiratory samples with the
Ah, perfect
respiratory?
question. That's exactly what was asked last week because there is no comparative parallel testing between the lower respiratory and upper respiratory in the same patient at the same setting.
Yeah,
Same setting is important. It's different if it's sequential. You do it one day here and next day BAL. That's different. Yeah.
right.
It's a setting. We don't have that direct comparison. Everything at the moment is based on some of our experiences. But the thing is, almost every virologist in UK, we all have created a WhatsApp group for them. We all discuss all these things, and everybody has got the same experience. Throat swab and nose swab negative in emergency department or admitted ward. Patient gets sick, iMobile is called, and they transfer the patient to ITU. And there, clinically, radiologically, lymphopenia, high dimer, CRP, everything typical of corona COVID. And then at the time of endotracheal aspiration, endotracheal, when they do the intubation, they take the aspirate and send it to us, clearly positive. These are all based on small numbers, but that's our collective experience. The virus has just transited through the upper respiratory, gone deep down. So you will get a false negative if you get the upper respiratory tract one.
What would be your advice to microbiologists and virologists in India who are working in a different?
Stop dealing with infection control issues and things. Let somebody else deal with those things. Stop dealing with every other seminars and meetings and talking to the ministers, all this blah, blah, blah. Completely, none of those matter now. What matters is focus on getting your extraction machines, your PCR machines, your assays, your reagents, your IT system. Because if you don't do that, come a week or 2 weeks or 3 weeks, the responsibility will fall on your head. You had the warning, you didn't do it. That's what's exactly happening here in UK. The labs where they didn't actually work on this, they're all being, I mean, they're really they're in trouble. So that's what I would say. Everything else, every other, you have about 2 or 3 weeks of time now. Everything else is superfluous. Sorry. Everything else is superfluous, all those meetings, everything is superfluous. Focus on the thing that we got to do. Set up your capacity, expand it exponentially in the next 2 or 3 weeks. You think, oh, where is the samples going to come from? We have a situation where we moved in Milton Keynes from 40 samples, and the requirement now is 100,000 a day. So that means you need to have the logistics people working on it. Unless we do that kind of, the Chinese have proven, so the South Koreans have proven, the Singaporeans have proven, for a change, the entire Eastern economy, the people who have sorted it out have proven that. Only in Europe, Iceland, Norway, and Germans are doing it in a big way. Also, I think, Norway, and they're all, you can see that if you do identify them very early on, you can prevent it. And then it becomes a social problem where people identify it, and then everybody will be aware of it, and they know that they have a problem. It's the classic Oxford Handbook of Clinical Medicine. What the mind does not know, the eyes do not see. So if you do not even know what is happening in the community, how can you make any policies of anything? And the virus doesn't basically affect just like China. It moves in pockets. Like today it could be Bangalore, tomorrow it could be Chennai, tomorrow it will be Kolkata, and then after 3-4 weeks it goes to Jammu and Kashmir. So once, let's say, you are past that outbreak, you have all this testing facility, you are past this outbreak, guess where you're going to get your new cases from? Importation. That's exactly what's happening in China. All Chinese new cases are imported. We will be in a vigilant state, which I don't know how it will think. I can't see the future. It will be like what we would do if we had a Ebola case from Sierra Leone coming to your place. What will you do? You need to be that 21-day thing. So we will be forever in this thing. So the virus is so well adapted. It's asymptomatic. People are spreading it. So we are not going to, and it's going to adapt to the human race. And luckily, from what I gather, the SARS original one, the antibodies produced are neutralizing. I just learned about it yesterday. There's so much of documentation coming. So that just means once we have the IgG, at least for 1 year, we are okay. So we don't know how the mutations happen, like the NL63 or the OC43 or 229E, whether there will be an IgG mutation, mutation in the proteins, and then that all your IgG is useless. We don't know that. So that means serology will come later on. But right now, the IgM is rubbish. We know that. There's not a single thing. Otherwise, UK would have had it. They're still evaluating it in Portendon on behalf of the government. The WHO has asked UK to basically evaluate every ELISA known, because the WHO and the CDC, and so they're doing it for the world here, because there's a long history of having a panel of seroconversion, a panel of various stages of infection to see where the IgM comes up, where the IgG goes up, and compare between assays. Those things haven't been done in Korea or Japan or thing. The guys manufactured, 7 days later, everything was available, they tested it. But it worked. That it worked because they did the social distancing. They were very aggressive in quarantining. Then they used the mobile phones to track people and trace people, and alerted everybody around this particular infected person. Hey, you were within 2 meters or 3 meters of this infected person. Go and test yourself. And it worked. Singapore went to a completely different thing. They had entire schools under lockdown, the church members under lockdown, arrested people. I heard the story. They had a person who was a student who came in, and he was given a tag and a phone thing, and he was told to stay back in his room, 14-day quarantine. He said yes, stayed for 2 or 3 days, left his phone and everything, went out. He was caught on CCTV. His face was recognized. He had 1 hour to pack up and leave Singapore because he broke the quarantine. Banned from Singapore forever. Now you're looking at that. That's the only thing that will work. But we are democracy. We want this freedom of expression and everything. So I appreciate all these things. But we have to be nudged into the right kind of behavior. So that will take some time in different countries to evolve into different things. So right now, what we have is testing, which is what we can control as virologists, nothing else. So that's what I feel. Can we control everybody else? We can't. We can control testing. So everything else is superfluous.
Before I say goodbye for the time being, I am tempted to ask one last question
Sure,
about
sure.
antiviral treatment, particularly hydroxychloroquine or anything
Yeah,
else.
be careful about it. The Chinese said, "Oh, yeah, everything is fine," but it is all published in South China Morning Post. None of the data has come out. Yeah, the Marseille people in France, they published something for about 19 and all these things. That particular paper has got so many flaws. The testing is incomplete. They didn't do the complete the testing. So, in other words, and also that particular group of researchers have a long history of. This is not for recording. They have a long history of publishing stuff which cannot be replicated anywhere else in Q fever and rickettsia. And I know that from my potent connections. So we don't trust anything coming out of that. So the moment I saw it, I knew the authors. Oh yeah, I'm not believing it, and that's exactly what happened later on. Everybody is saying this is a flawed study, and the French government has gone ahead and authorized hydroxychloroquine in a big way with
For
zero
treatment.
trial. Yeah, treatment, big way.
Yeah.
See, here it's part of everything is now on trial. So it's part of as of yesterday, 900 people are on a trial for hydroxychloroquine on one arm and other something else on another arm, standard treatment. So unless it's part of a trial, you cannot believe all these people who say they're going to cure anything. So again, the field has become so big. I have taken a step back because it's the ICU have their own problem, the obstetricians have their own problem, pediatricians have their own problem, and they're all part of the ethical thing. Where you need to recruit the patient, give the consent, they have to be follow strict guidelines and all these things. So I basically walked away from this because under normal circumstances, I would have been very involved in advising.
A move toward using hydroxychloroquine as prophylaxis. Any comments on that?
We don't even know about treatment. What about prophylaxis? That's the next stage, isn't it? I
Okay.
mean, I'm sure there are people who are looking at it and in depth, and the fact that it's easily available and everything, and with all the complications of cardiac complications, God knows whatever. So I'll just say, yeah, Harrison said it. It's got some episomal issues and everything. Yeah, fine. In vitro, fine. We don't know whether it works. Yeah, unless the data from China for those massive whatever trials or case series actually comes back completely controlled and everything with all the confounders taken away. I wouldn't trust any of these things. Yeah, in desperation, you'd probably give it because there's nothing else. But we don't have robust evidence for it.
Thank you, Sudhanva, for your time.